Ladies and gentlemen, please welcome on stage Professor Vincent Vidal.
Thank you. Thank you for the invitation. Okay, I'm very happy to be here. So the title is Interventional Radiology, which used to go to Mars. Who here can talk 2 minutes about interventional radiology? Nobody. Who can talk 2 minutes about Mars? I'm quite sure some of you can. It's interesting, you know more about Mars than about interventional radiology, and you are medical students. That's strange, but there is a direct link between that. May I have the slides, please? So, you know what is it? This is an International Space Station. There are people inside for years, for more than 15 years. There is no specific medical need in that. There is some needs. But you know the distance between the Earth and the station is less than the distance between Los Angeles and San Francisco. It's very close. And in this station, you have, of course, astronauts who are really healthy. But they have a direct link with the Earth. They can speak to Earth, they can speak to us, they can speak to physicians. They have plenty of things in the station. Even if there is something which is really, really bad conditions, medical bad conditions, do you know how many time it takes to have an astronaut from the stations to a good hospital around the Earth? It's less than 24 hours. So that means that for Thomas Pesquet, for example, our French astronaut, if he had something which is really bad, we know that we can discharge him in less than 24 hours. That means that normally in the station, in these stations, there is nothing really bad for medical conditions. We stabilize the patient and he go back to Earth. Slide, please. This is not the same movie. We want to go to Mars. We are going to Mars. 15 years, 20 years. Here it's not Los Angeles, San Francisco. It's around 300 to 400 kilometers. It's a very, very huge distance, very huge trip. It's like 9 months of trip, okay, to go. After you have to stay 18 months at least, because we cannot go and come at the same time, and we have to go back after. It will take more than 900 days. Here in these conditions, you can imagine that the astronauts will be completely on their own. The other point that you perhaps do not imagine, with this distance of 100 million kilometers, you cannot speak to Earth. When you speak to Earth, when the astronaut in Mars says, "Hi, I am here," it takes 20 minutes to come to Houston. And your son said, "Okay, I'm going to call the doctor." So you are on Mars, you said, "I am here." 40 minutes later, you have the answer, "Okay, we're going to call the doctors." So that means do not work. They are completely in complete immersions. So there are plenty of issue about that, but the medical issue, of course, is really, really important. So we always imagine that they are going to Mars in this kind of ship, but this is movie. The ship are not like that. And this is one of the biggest issue slides. It looks like that. This is Thomas Pesquet in the stations. There is no space. No space. That means if you have no space, you cannot bring big volume of things to treat the astronaut. Slide, please. We have to bring water, food, of course. We have to bring fuel, gasoline, communication system, the crew members, all the stuff. That will be very complicated. Slides, please. In this crew member, all the crew will be probably 5 or 6. There will be one physician inside. We need a physician. It will be a specific physician. He needs to have some idea about ICU, of course, but of small surgery, traumatology, dentistry, all these kind of things. And he will have to know to do interventional radiology. Why interventional radiology? Because interventional radiology, and for people who have come to the central line before midday, you see that with only an ultrasound probe, and some small device, you can go inside the body and treat a lot of things. 10 years ago, it begins. You see this paper, The Final Frontier for Interventional Radiology. There is no space remaining in the shuttle to go to Mars. They expect that the medical device need to be less than 700 kilos. That means 1 meter cube. So it's very low. Please, slide. So interventional radiology, what is that? In 1953, Mr. Seldinger, which was a resident, he had common access of bone sense, he said, common sense. Slides, please. He had the idea that with a needle, he can puncture a vessel. In the vessel, he can insert a wire. With the wire in place, he can do a small incisions and insert a catheter in the vessel. If you can do that, you have a direct access to the vessel. So he developed that. And what does that lead? That leads to angiography and all the way to go inside all the systems that you can imagine, urinary system, biliary system. Why radiologists who do that? Because we do that under X-ray. We see with the X-ray where goes the catheter in the body. That's why interventional radiology began. When Seldinger go and see his mentor, he said, I have found some things really interesting. He said, yes, that's great, but you cannot use that for your thesis. It's not enough. That was huge. Slides, please. So it began the angiography. Here you see an angiography of the liver. There is here a tumor of the liver. Between 57, 56, and the 80s, there was no CT, no ultrasound. So the only way of seeing tumors, kidney tumors, liver tumors, all this kind of thing, was to do an arteriography. So radiologists have developed new catheters to go as far as possible in the body, from here, from the ground, from the femoral access, go inside the brain. So this is the next step. Its daughter, which is the other father of interventional radiology. He do a lot of angiography, and one day he do a renal angiography. And when he go back, he pull out the catheter, he see that he had crossed an artery which was completely blocked. That was like a mistake. You don't have to do that. But he said, if I can cross an artery which is blocked, accidentally, I can do it for a good goal, to do a repermeabilizations. And he has this idea, he said, with my wire, I can cross the artery. So he go and ask the surgeons and said, do you have any patients that I can treat endovascularly with a wire? And they said, no, we haven't any patients to do that. It's too dangerous. But finally, slide, a patient, this was the first patient, she had a diabetic infection, and she don't want to be treated on his femoral artery, and she don't want that the surgeons cut her leg, so she said, I'm going to die. And the surgeon said, okay, perhaps on this patient you can do something on his artery, on her artery. And he said, okay, I'm going to try. So he has punctured, slides, please. He has punctured the femoral access. He has go down to the, you see here, there is a big stenosis, very tight stenosis on the femoral artery, and he has dilated with these slides, and the patients recover. Slides. You see this is a real map. Slides, please. This is a real woman, the first woman which has been treated by interventional radiology. She's looking at his artery. That was the beginning of saying, okay, we can go through an obstruction of the artery without surgery. So he began to do a lot of things and works with some industry to have new catheter, new balloon to do dilatations. Slides. During the 70s, we do still a lot of angiography, and one of the first patients which has been treated by embolization is these patients. We think at the contrary. Here it's a patient which had a pelvic fractures, and he has a bleeding on the arteriograms. you see here on the middle, the picture in the middle, there is a false aneurysm bleeding here in the hip. And the interventional radiologist, who he has his catheter just in front of his bleeding, he said, why are we going to discharge this patient to surgery? I am just in front of the bleeding. Perhaps I can block this artery. Of course, at this time, he has nothing to block. Now we have plenty of things, cords, glue, all these kind of things. But at this time, he has nothing, but he was really bright. He said, okay, I'm going to take some blood of the patients. He put it on the table, just make it a clot, and re-inject a clot. And with injecting a clot, it do an occlusion of the vessel, and finally, the vessel was blocked, and the patients do not need to have a surgery. It was the beginning of embolizations. I mean, without any surgery, just coming from the groin, from a small hole, we can deblock the vessel, or we can close the vessel. Please, slides. So here is the example of what we are working for, specifically in our country, but in an emerging country. Here you see the catheters is inserted in the ground, in the femoral artery. And finally, with the catheter, you go in the uterine artery. You see there is a bleeding. There is a lot of women who died of postpartum hemorrhage, especially in emerging countries, because they don't have this kind of technology. To do this embolization, slides, please. You see here the blue things. We have inject some things to block the artery, and the patient will not die. To do this, you just need a needle, a wire, a plastic catheter, and some threads of suture or glue, and you do the job. If you cannot do that, you have to do, for example, an hysterectomy, or if you cannot do an hysterectomy, the patients can die. So that's really important. I think that people are not still aware of interventional radiology, but we do that. We do that every day. And also for uterus, we treat the fibroids. When there is tumors, benign tumors, you can do an hysterectomy, but you can also block the artery of the fibroids, and the fibroids will decrease. And the patients go as well as surgery, but they don't have a surgical wound. So interventional radiology grow better and better. Okay, so you said, what is the link with Mars? We're not going to embolize fibroids to astronauts on Mars. No, of course not. Slides. Here is another trouble. This is an MRI. You see on the left side, the white area is an ischemia. This patient has a stroke. Now, since 5 years, if you have a stroke, if you are lucky to be in a university place in Europe or in Asia or in the States, you can go to MRI. If the MRI say you that it's an ischemia, you go to the angio suite in neurointerventional radiology. We go from the ground, we go inside the head. Here you see there is a anterior cerebral artery. There is no more middle artery. Slides. So you see there is a clot. We go inside the clot with a small stent. We expand the stent. Slides. We retrieve the stents. We retrieve the clots. Slides. And finally, you see here is the middle cerebral artery, which is there. When we do that in the first 6 hours, more than 60% recover completely of the symptoms. That means they have no hemiplegia, no aphasia. So you have seen, go out, open the artery when it's closed, close the artery when it's bleed, reopen the artery when there is a thrombosis. We can do plenty of things. Slides. There is also, this is all endovascular access, but we do a lot of things percutaneously. Slides. Here, you see there is an abscess from an appendicitis. He had a surgery, there is an abscess. You have two options. You can do again a surgery, or you can insert a drain. To insert this drain inside the skin, you can use ultrasound, you can use CT, you can use MRI. This is very easy because just under the skin, slides. But we can do some target, which are really more difficult. Here, the patients, we go here from the back to do a biopsy of the adrenal gland, to have a samples and to know what is the good treatment, the good diagnostic. Slides. Here, we're going to put some corticoids in the articulary, in the spine, to treat pain. It's also interventional radiology. Slides, please. And here, it's thermoablation. Now we do a lot of thermoablations. It can be from heat, from microwave, and also with ice. On the left side, you see we put a needle with a small probe, and it delivers some alternative electricity, which increase the temperature to more than 70 degrees and completely destroys the tumor. You can do that in the lung, in the liver, in the kidney, everywhere. We can do also, for example, in the kidney, do it with cryoablations. That means with congelations going minus 20 degrees. Slides, please. So here you see, this is a tumor of the kidney, which is a median tumor. It's not a big tumor, but it's the middle part. So you cannot do a half nephrectomy. You have to remove completely the kidney. Instead of doing that, you can insert under CT or under MRI 1, 2, 3, or 4 needles, which is going to conduct the ice, and we are going to do the cryoablations during 10 or 15 minutes, remove the needles, and the patient is treated. That's also interventional radiology, percutaneous. Slides. So on the left, it's the table where we do interventional radiology endovascularly. And on the right, you see this is CT, and it's almost the same for MRI. So these are, in our department, how we treat the patients. Of course, this very huge device will not go to Mars. It's impossible. Do you remember that if we found gold on Mars, we will not bring back? Even gold, it's not enough expensive to bring it back. So it's here, slides please. You have seen this morning ultrasound with me. Here is a new ultrasound. So this is the size of the ultrasound. It's like here, that. So that you can bring it in the space. You can bring it in the stations. Slide. So since 1961, Kennedy, and finally today, there is more than 500 people who have been to the space. There's not a lot of aborted missions. We see that most of the things which happened was traumatic injury or things really related to microgravity. But one of the aborted mission, a Russian mission, is very interesting because it's a prostatite. Slides, please. The patients had a prostatite. He has a kit to put a drainage from the penis, but he cannot do it. He cannot manage that. So they aborted the missions. For an interventional radiologist, it seems completely incredible because it's so easy. Slide. With ultrasound, you see here you have the bladder. You just insert the needle, the wire, you put a catheter, and that's done. It takes 5 minutes. Everybody can do that. You have done that this morning with the central line. Everybody can do that. So if you are on the stations, international special stations, it's okay. You can go down. But on Mars, you can die of that. If you cannot pee, you die. That's clear. Slides. So this is all the medical conditions that the NASA and the European Space Center have listed where we can have some things to do. But there is very specific pathology for interventional radiology. Slides, please. Here you see the cholecystostomy and the drainage of the kidney on the right. The astronaut, for different reasons about microgravity, do more lithiasis, kidney lithiasis, than the other people. So in 900 days, it can happen that an astronaut do lithiasis. If you do a small lithiasis and it comes from the kidney to the bladder, and if you can eliminate it, it's perfect. If it blocks in the ureteral, the astronaut can die from a septic shock. It's not really complicated to do that. with ultrasound, putting a needle in the urinary cavity and making a drainage. The same for cholecystis, and there are plenty of other indications I'm going to speak with you today, but this is clearly where we do it. Slides, please. So the drainage set that you have seen this morning, if you look at the introducer needle, the wire, and the catheter, it's 210 grams. And it will be used for jugular, for liver, for kidney. It will be the same. Slides. So this is what you have. You have a wire, needles, a syringe. Slides. And this is the drain that we can insert. This is blue things with some holes that you can insert to do the drainage. Slides. So at the French Society of Radiology, we have promoted a challenge last year. For 1 year, 6 teams have worked on building the best toolbox for interventional radiology for Mars with the French National Space. Slides, please. So they have worked so much that some of them have done some tests in the water, to be sure, because in microgravity, you remember when you insert just a needle in the jugular vein, when you are here, the blood comes on the table. In the space, it comes in the capsule. So you have things everywhere. You cannot put your wire on the table. There is no table. So everything needs to be scratched. Everything needs to be rethink and rebuilt to have the sets. Slides. So you see here insertion of the catheter in the swimming pool. Slides. So this is one of the toolbox that we had. This is not this one who have win the competitions was the most beautiful, but just to have an impression. Slides. So to finish, here you have on the map of the top the health access and quality index. You see it's completely related to the life expectancy. That means that if you live in a blue country, like us, you are lucky. If you live in a red, purple country, it's not the same thing. Why I said you that? Slides. Here you see the United States. There's around 100 radiologists per million of people. In Africa, in Western Africa, it's less than 0.3. I am training right now interventional radiologists from Chad. There are 10 radiologists in Chad, 10 for 16 million people. She's the only one to do interventional radiology. So that's difficult. They don't have a lot of devices also. Slides. So on the top left, this is Mars. And on the right back, this is my wife in Wadi Rum in Jordani. It seems really the same, no? Okay. If I have to drain some things for my wife, I need some tools in this place. So this is really interesting that anytime we work for space, we bring back things to Earth. And the toolbox we are building now, we are first going to use it in emerging country before using it to Mars. Slides. So this is 20 years after coming to Mars. Slides. This is 20 years later. You see that they don't have anymore their helmet because now the briefing is easy on Mars. And on the top left is the Interventional Radiology Center on Mars, you see? Okay. Slides. Thank you.
Thank you so much, Vincent. It was pretty interesting and a nice link between the past, the present, and the future.
I just had a simple question. It's why they can't speak normally on Mars?
Why they cannot speak normally on Mars?
Why can't they urinate normally on Mars?
Oh, no, they can. They can. They do more lithiasis. They do more lithiasis, so it's a possibility that one of them do a lithiasis, but they have the normal function on Mars. Not completely normal, but subnormal.
Not completely normal, but... Okay, second question?
You talked about having like a small machine to do, you asked, but we still don't have the same thing for X-rays. So do you think we can go to Mars before having those the scanner on a small scale and stuff like
Yeah.
that? We can.
Yeah, we can. So
Because-
we still have some in the spatial stations. They do some experiments to have X-ray. The main problem of X-ray is energy. It needs a lot of energy to have the power to deliver X-ray. So even it's a bit heavy, but we need a lot of energy, and energy it's clearly an issue in the space. So probably we'll have, but
And also to protect the other people, because X-rays, it's irradiation and stuff like that, or do we not think about that?
yeah, the problem of X-ray radiation for them is nothing because they have a lot of problem of radiation. It's one of the big issue. They will have for the trip to the moon, I think it's 5 microsieverts. For Mars, it's more than 2,000 microsieverts.
So a
It's
scan
so
of
important that they will need to have the water, the water tank will help them. They will have a place inside the water tank to protect them when they will have solar eruptions. Because these radiations are so bad that they will need to have this kind of protection for perhaps 6 or 8 hours during the time.
Okay, so we're still waiting for the scanner machine to get smaller before they can
Yeah,
go.
we can do really smaller, yes.
Okay, thank you.
But so just like in the previous conference, you know, there's so many parameters that you can just focus on one to solve the problem. Mainly it's going to be an
Yeah.
issue and a correspondence of parameters before being able to solve the issue.
But anyway, the biggest issue of this trip is clearly to spend 9 months in a small box with 6 other people. It's clearly the biggest issue that that we don't know how to solve it. It's in the stations, when they take their rest, they have their iPads, they speak with the family, they do FaceTime, they have a normal life. Here they will have no contact. So no normal life, no things like that. It will be really, really more difficult.
Is the echography enough of a diagnostic tool by itself? Because you were showing us some examples with contrast to see some important pathologies, but I think it would be another problem to bring this kind of product with them. So would it be enough of a diagnostic tool? That's a question. Thanks.
So interesting questions. In the world of space trip, they just think that is it a possibility that happens or is it a possibility or not? And if one things may happen one time in a century, should we take care of that? So we said yes or no. If we say yes, we have to treat it. So your question, you said, is it enough ultrasound? Is it enough for plenty of situations? And we know that for the other situations, there is no solutions. So we don't want these solutions appeared. But we have now some ultrasound. They are working specifically on that. You just put the probe on the body, and he does a scan himself. And like the patient, the astronaut has been scanned before, you can see what are the pathology. So it's evolved a lot. And we can imagine that we are going to bring with them the images, the native images that have been taken on Earth. So if you have to do some things, perhaps you can do it with 3D reality of their own city, which has been done before. So it opens a lot of things that we are going also to use after, not after, before. Before. So it's not enough, but we can do a lot with ultrasound.
Most of the procedures you showed us were permanent solutions, but I had one specific question about the kidney drainage, the urine drainage from the kidney. Is that more of a temporary solution, or is it also permanent? Thank you.
Thank you. It will be a temporary solutions for the astronaut at the time he come back, of course. It's clearly, again, when we work with them, with the special physicians, they said we prefer stabilize the patients than treat the patient with something which is dangerous. So stabilization is the way. Stabilize. It's big enough.
Thank you.
Yeah, knowing that the delay is going to be huge
Yeah.
for the moment, and that there needs to be some kind of auto procedure that they're able to do by themselves.
Yeah.
But not too complicated.
Not too complicated.
In order not to
yeah.
mess things. Okay.
That's really complicated. So.
Ladies and gentlemen, do you have other questions about the application of human technology, like far, far away?
Who want to go to Mars?
Yeah.
Elon Musk said, I am okay to die on Mars, but not at the landing.
Well, but I mean, what's your point of view about, developing all these kind of technology for an future if or when, depending on the point of views, where we still have so many things to do here? What's your point of view on that?
Yeah, it's always something that we can say about the spatial conquest. For me, it's a dream. We need to dream. So it's not so much, it's a lot of money, of course, but it's not so much money. And it gives so much advanced research that finally, most of things, we use it first in the Earth. That's clearly the fact for us with this toolbox that we are going to. The team who have worked for 1 year on that in France, it was the result of the challenge 1 month ago. They have all said that it was a great time of working, of team working, team building, and it makes some dreams in our heart, and I think that's great for physicians, because it's not so always easy at hospital.
So the spatial exploration, as we could call that, space exploration, is actually giving tools for application in the real world here.
Of course, and it's a model of things, the model of aging. So it's really interesting. It explains us a lot of things, especially not for interventional radiology, but for radiology. We also have a challenge, which is a data challenge, because it's the same artificial intelligence, which, for example, looks for lung nodules that form the surfaces of Mars. So we are working together because it's the same things. So anyway, everything is linked.
Professor Goldman was mentioning that the development of the AI obviously is making the diagnostic easier, but still in space, and especially astronauts, they're usually like the better version of us, knowing a quantity of stuff and being able to do things by themselves, a little bit like MacGyver. We were talking about that beforehand. Do you think that the goal indeed for the general human would still be to be more educated when it comes to the general medical knowledge?
Sure, it's a big question.
That's a big topic.
Yeah, of course. I think we need to be more educated on general knowledge. Yes, that's clear. And this kind of astronaut can really do. This morning we have done insert some central line, and the 10 or 11 who have done that, they have done it very well, and it was the first time, the first steps. So clearly they can do that, yes.
Autonomy in space.
Autonomy in space.
Ladies and gentlemen, do you still have a question? Well, thank you so much.
Thank you for
Professor
the invitation.
Vincent Vidal.